Starting webinar 1, 2, 3. Good evening, everyone. On behalf of the New Jersey Division on Civil Rights, I'd like to welcome you to this webinar titled Black Men's Mental Health, I Am My Brother's Keeper. Before we get started, I'd like to go over a few housekeeping items. This program will be recorded. The recording will be made available soon on our website at njcivilrights.gov. Given this is a webinar, all audience members' cameras and microphones will be off. Your participation is important to us. If you have questions, please drop them in the Q&A tab. Questions can be directed to all panelists or a specific individual. Questions can also be submitted anonymously. Due to time constraints, please keep all questions on topic. Resource links and contact information will be shared in the chat tab throughout the program. If you experience any technical difficulties tonight, please explain your problem through the Q&A tab, and we will try our best to address the issue. Lastly, please follow the New Jersey Division on Civil Rights on Facebook and Twitter at Civil Rights NJ for the latest news, resources, and information from our office. I now turn it over to the Deputy Director of Community Programming for the New Jersey Division on Civil Rights, Patricia Williamson.
Thank you, Kai. Good evening, everyone, and thank you so much for coming. Welcome to tonight's New Jersey Division on Civil Rights webinar, Black Men's Mental Health, I Am My Brother's Keeper. On behalf of my Director of Outreach and Community Relations, T. Leonardo Santiago, and Director of the Division on Civil Rights, Sandeep Iyer, I bring you greetings. Tonight's webinar is going to center around mental health. As you know, this is Mental Health Awareness Month, which is a national movement since 1949, dedicated to eradicating stigma, extending support, fostering public education, and advocating for policies that prioritize the well-being of individuals and families affected by mental illness. 1 in 5 U.S. adults experience mental illness, and only half of them receive treatment. Annual treatment rates among United States adults with any mental illness for non-Hispanic, Black, or African American, that's 39.4%. For males in general, it's 40%. We also hear that people with depression have a 40% higher risk of developing cardiovascular and metabolic diseases than the general population. And people with serious mental illnesses are twice as likely to develop these conditions. One of the things that we want to talk about is stopping the stigma. In the Black community, we have we usually have faith and social communities which are more aware of mental illnesses, and we want to be able to help people besides just saying, pray about it, and it will go away. We are starting to have that conversation. And when in the Division on Civil Rights, this is our second conversation in 2024, specifically towards the Black community. This one is towards Black men, and we really want to focus on how to tell what's going on, what the mental health awareness impacts are, and what can the community do, what can you do, and if it's you, what can be done. So I'm very pleased to be able to bring this information to you this evening. What I'd like to do now is begin to introduce our panelists. We're going to have 2 sets of panelists. And the way we're going to do this, we're going to have a few people have a conversation, then we're going to add to the conversation. And so just give me one moment. Our first panelist is going to be Dr. David S. Arnold, MD. He was born and raised in Brooklyn, New York, and he's a psychiatrist, currently serving as the Director of Psychiatric Acute Inpatient Care at a state hospital located in Maryland. He was honored by the former mayor of Baltimore with a citizen citation for your outstanding leadership and provision of excellent mental health services to the community, while serving as the Executive Vice President and Chief Medical Officer for the Urban Behavioral Sciences Group Practice. He is a life member of Omega Psi Phi Fraternity Incorporated. So welcome, Dr. Arnold. Next, I'd like to introduce Dr. Willard W.C. Ashley Sr. He has over 42 years of experience as a pastor, has served 4 different congregations, and is currently a pastor at a church in Jersey City. He also had a role as an instructor in the Doctor of Social Work program at Rutgers School of Social Work, New Brunswick campus. And he is one of the few African-American psychoanalysts in the country. So we welcome him as well. The third person I'd like to introduce at this time is Mark T. Williams. He has over 50 years of psychiatric nursing experience and is ANCC board certified in psychiatric and mental health nursing. He is currently the president of the National Alliance on Mental Illness, New Jersey Board of Trustees. So welcome to Mr. Williams as well. We have other guests and they will be coming on shortly. So what I'd like to do is start the conversation and base it on the medical aspect. So my first question is going to be, how do mental health issues present themselves in Black men? Are they different than in other races and genders? And I will start with Dr. Arnold. Oh, Dr. Arnold, you're on mute.
Sorry about that. I want to thank you for inviting me, to join this panel, and it's a fantastic move towards getting the word about mental health out to the community. When you ask about, if it presents differently in Black men, yes, there are vast differences compared to the rest of the community, and those differences are based in our past history. Of how we arrived in the country. And when I say that, we often think of the Black community as being monolithic, but we actually have people from all areas of the globe. So we now can see our Black community is comprised of people who have ancestry in the slave trade, who are here, but we also have people from the West Indies, from Africa now, from other regions of the world who make up the Black community. So it's a very diverse community. And often we try to say that it's a monolithic, that all Black men are essentially the same in some ways. But the way we have to deal with mental health is in the context of our environment and the pressures that we have, both socioeconomically, in terms of the structure of our communities, and our communities are also diverse. So when you look at Black men, we have people who are wealthy, people who are middle class, people who are on the poor end of the spectrum. So they have different pressures, different structures to operate through, and have different advantages or disadvantages based on their income, based on their location. So it does present differently in terms of the way we are raised. However, one of the things that's almost universal is the sense that I can take care of it myself, that I don't want to depend on a system that has ostracized me or castigated me over the centuries. And so for me to put myself forward and say that I have a problem and having a difficult time dealing emotionally with what I have to deal with on a daily basis is difficult. And my initial presentation may be that I come in not for depression, but I come in because I'm having headaches or because my back is always hurting, or I always have that it's hard for me to sleep. So you see more somatic symptoms that come out, and that person is seen by their general practitioner. They may prescribe something for their sleep, for their backache or whatever, but never delve into, okay, what's going on in your life now, and what are the other symptoms you're having, in terms of depression. Also anxiety, is a greatly underdiagnosed illness. And what we'll see is that in order to cope with some of the somatic symptoms, people will often use things like alcohol or drug use. And then with the stigma that's put on Black males in our country around that subject, they are seen as a substance abuser or as an addict when they come into the office, rather than someone who's depressed trying to cope with their depression. So those are some of the barriers that we run across.
Thank you, Dr. Arnold. Did Dr. Ashley or Mark, did either of you want to follow up on that?
Yeah, I appreciate, again, like Dr. Arnold said, thank you so much for the invitation to be part of this panel and to be able to add some of my insights on that. So in addition to what Dr. Arnold said, I have found that the Black men I see come in because of irritability reported by the family and or anger. And so I'm not as eloquent as Dr. Arnold. So I'm gonna just be blunt. The Black men that come to see me say, "Doc, I'm sick of white people." That's why I came to therapy. Now, from that, we may break out other issues, but that's the chief complaint. That's the presenting problem. And it doesn't matter if they are a judge, the CEO, a professional athlete, or just an everyday blue-collar worker. That is usually the presenting problem and the chief complaint. And so from that, we can get depression and all the other DSM-5 TR diagnostic categories. That's what gets them to walk in the door usually, unless a family member says something's wrong and they go in for that reason. That being said, Dr. Arnold's colleagues have written about this more recently in 2 publications. Dr. Beverly Stout has written a plethora of articles, but her most recent book is The Trauma of Racism. And then yesterday in Brooklyn on Fulton Street, in addition to being Biggie's birthday, we celebrated Dr. Benny Prim, who they named a part of Fulton Street after him. If you don't know Benny Prim, look it up. Shame on you. Because Dr. Benny Prim, back in the 70s, said that Black men and women present differently, and that we cannot just look at one part of the body. We have to look at it holistically. And in looking at it holistically, to what Dr. Arnold said, there are a plethora of challenges that our European white colleagues don't experience that impacts how we present and impacts how we come across in the room with therapy, if we even get you in the room at all. And I'll stop there.
No, that's fine. Thank you. I'm going to ask the next question. We're already starting to answer it. And Mark, I'm going to come to you with this one. What are some, like I said, some of this has already been answered, but what are some effects of depression, schizophrenia, and stress, and any of those other, some of the other mental health disorders, especially for Black men? What are some of those effects?
Yeah, can you hear me? Testing 1, 2, 3.
Yes.
Yeah, from my perspective, I don't know that depression manifests itself differently in Black and white men, but from a cultural perspective, how it is dealt with and the effect it has on individuals and families can be very different. Culture and environment can have a significant influence on the length and the severity of the depressive episode. Sources and severity of stress may also be conditional to a particular culture and environment. Systematic racism realized in poverty, food insecurity, homelessness, substance abuse, inadequate access to healthcare resources, community violence, etc., can all be a significant source of stress, not presented in a meaningful degree in other male racial groups. The African American may be misdiagnosed with schizophrenia because of implicit bias, mistrust that results in answers to the interviewer's questions that are guarded, and the individual may seem paranoid. One item I'd like to piggyback on with Dr. Arnold mentioned was substance use and how it equals self-medicating. We often look at our young men standing on a street corner or hanging out in an urban community, drinking alcohol or smoking pot, and we often have a negative view of this type of behavior. It's important to understand that because of the lack of access to appropriate quality mental health care, that these individuals could very well be self-medicating. So let's not jump to conclusions about behaviors automatically having a negative circle around them, but look a little bit deeper and try to understand why are these individuals using substances, and can they get access to quality health care so that they won't have to self-medicate. I also wanted to make a comment on gender issues because of how we view the role of men and women in the African American community. Yes, mental health issues can present themselves differently, not only in terms of gender, but in our gay, LGBTQ communities and our transgender communities. I'll end there.
No, thank you. That was actually going to be my follow-up question. Perhaps the differences may not be so much between Black men and white men, as you mentioned, Mark, but perhaps between Black men and Black women. And there may be a difference in how things are presented. So, Dr. Arnold, did you want to follow up on that?
Yeah, sure. And I think what Mark was mentioning about the it's kind of the criminalization of the symptoms that we see, and it had a political significance in the sense that when the Republican Party started criminalizing things, saying your house is in danger from all these people on the streets and the shootings and all these bad Black young men out there killing people, it's been politicized, and so now when Dr. Ashley mentioned, the anger that he sees, a lot of anger in the people coming out, and we see anger in our young men, and it becomes a way of channeling that anger by being out there, by drinking, by saying, the heck with the society, the heck with, the government, and we see that, and so. And then it becomes criminalized. So there's a very good book that came out called Madness, and it was written by Ortunia Hilton. And what she did was went to one of our local hospitals here, State Hospital, Crownsville. And Crownsville was built back in 1911. And at that time, they used people who were former slaves to build a hospital. Okay, but they were the original patients of the hospital. And it's a very telling book about how we transitioned the mental health system from the slavery into the mental health system. And what that mental health system's, the purpose it served at that time was that Crownsville allowed Black patients to come in. The other two state hospitals wouldn't allow Black patients. So they had to build their own hospital, and they saved the state thousands of dollars, equivalent to millions of dollars a day, by building it brick by brick by hand. Okay, and it was all African American men and women started coming in, and they were putting them in there to get them out of society because they said they didn't know how to handle themselves. They didn't know how to control themselves because they were free now and they had no guidance, no structure to operate within in the community.
Mhm.
Okay, so that was the beginning of the mental health system here in Maryland. And so the idea of trusting people, with your mental health and not knowing why they're pulling you in there, and they pull people off the street just from walking around, being vagrants or whatever, but it criminalized mental health. And it's still criminalized today because the state hospital where I work, 99.5% of the patients come from the judicial system, from the detention centers,
Mhm.
try to get restoration to competency to stand trial. Okay, so there's still a criminalization of being mentally ill that's predominant in that system. And so given that tied with the stigma that people have where they don't want to be mentally ill or identified as having a mental illness, makes it even more difficult for people to come forward with that. It's easier to come forward with other symptoms and not what the real problem is, you know. And then you add to that, like if you look at our communities, about 27% of African Americans live below the poverty level in this country still, today.
Mhm.
90% of African American households are headed by women with no husband present, as compared to 9% of white households. Okay.
Okay.
And I always say that we're in a state of PTSD following slavery, that our families were fractured, our communities were fractured, the neighbors were fractured, and all the rest. But still, and that's, it points to a problem, but it's not the predominant picture of our community. Because I forget the brother's name, but he did a study where he found that there are more young Black men in college than in all prisons combined,
Mm.
prisons combined in the United States. But you won't see it in the media.
Mhm. Mhm.
You will not see that. And it's because they want to criminalize Black males
Okay.
because it profits them when they're running for office. They can say, "Oh, there's crime in the city. I'm getting rid of that crime." Just like Trump, President Trump used the thing of the rapists, the murderers, they're killers coming into our country. So if you can criminalize a group, then you can use it to your purpose politically to gain office, and that's
All right.
never been addressed. But anyway, that's okay.
So thank you. So you've already answered a third of the next question. So what I want to do before we move forward, two things. One, I want to bring in our other guests. First, let me go ahead and bring in our other guests because they have some input on here as well. First, I'd like to introduce Anthony Ebony Davis. He is the Brother You're on My Mind chair for the 2nd District of Omega Psi Phi Fraternity Incorporated. And I would also like to bring on Raquel Romans Henry. She's the Director of Policy, Salvation, and Social Justice. Both of their names, both of their bios are in the same agenda and bio document that was dropped earlier. Let me see. Did want to mention a little bit more, so sorry about that. Ebony Davis is a historian, a humanitarian. Is soon to be an author of his first book. He is a graduate of Cheyney University, and he is in the Patterson area. And Raquel Romans Henry, she is an advocate and a policy expert. She is a strong advocate, and it's led to several statewide policy changes, one which you will hear about very soon. And she earned her master's degree in public policy and international relations from William Patterson University. So welcome, Ebony and Raquel. So I want to so everyone should be on. Yes. And then the other thing I need to say is that the The views and opinions of our guests are not necessarily those of the New Jersey Division on Civil Rights or the Department of Law and Public Safety. Thank you. So now we will continue, and we're going to ask the same question. Well, I didn't ask it, but we're going to continue with the same answers that you're already starting to hear. So I'm going to actually start with Raquel, and we'll continue this. How can discrimination, trauma, or systemic inequities impact mental health for Black men?
Well, good evening, and I just want to say it's such a pleasure and an honor to join such an esteemed panel on this very important issue. I think my fellow panelists laid it out quite aptly, but I'll offer, I guess I'll just offer this contextual framework in the sense of what's happening in New Jersey. So while we know that mental illness does not discriminate, it can touch your life whether you are young, old, Black, white, rich, poor. While mental illness doesn't discriminate, we know that we exist within a society that certainly does. And that discrimination shows up in the racial disparities that permeate every facet of our society and its institutions. So in New Jersey, for example, we have some of the starkest racial disparities in the nation. There is a $300,000 racial wealth gap between Black and white residents. We have the 4th highest maternal mortality rate in the nation, by which Black women are 7 times more likely than white women to die before or after giving birth. And our Black babies are 3 times more likely than white babies to die before their first birthday. In New Jersey schools, we are the 6th most segregated in the nation and the most segregated in the North, adversely affecting scores and scores of Black children, subjecting them to disparate conditions, such as overcrowded classrooms, insufficiently staffed schools, limited access to resources and opportunities. Then those same Black children are almost 18 times more likely to be incarcerated than white youth, despite the fact that Black and white children commit offenses at similar rates. Moreover, Black residents in New Jersey are incarcerated at 12.5 times that of white residents. And we make up just 15% of the population, but we represent 43% of the arrests for drug violation. We're more than 3 times more likely to be subjected to police use of force. And then depending on where you find yourself in the state, that goes up exponentially. For example, in Lakewood, New Jersey, Black residents are 22 times more likely to face use of force by police. So, just considering, that framework, we really get a picture of the immense stress that Black families, Black men, Black women, Black children are under. Nationwide, Black people are killed by police at much higher rates than white folks. So I say all this to say that we know that race is central to the lived experience of Black people, and it extends beyond the phenotype, and it informs our societal norms, our traditions, and yes, our collective traumas. So while all people experience mental health issues, the unique and specific history of anti-Black sentiment that has informed policy, serving as the very framework for every institutional structure that we interface with, requires that we acknowledge the specific methods of healing that we may need, as well as that we assume some community-led solutions to the problems that continue to perpetuate or be perpetuated by these structurally racist systems.
Thank you. I can take one more comment.
I need to just add to what Sister
Okay.
said so eloquently. And I know it's, I'm like being back on WNJR and KISS FM again. The views expressed on this channel, we got through that. We need to be very clear and understand who I'm saying this to. And I stand in front of the governor, in front of the attorney general. New Jersey ranks #1 in the nation in putting Black men in state prison. And the wealth gap increase is now 350, and it's #1 in the nation. The wealth gap in New Jersey is #1 in the nation. And the Latino Action Network just won a major lawsuit about discrimination in our public schools. That's always in the mix.
Wow.
And this is Mark, just to piggyback on what Dr. Ashley just shared with us, that the prison industrial complex is the largest provider of mental health services in the nation. Think about that. The prison industrial system is the largest provider of mental health services in the country.
Yeah, and then
That is-
with that,
Mhm.
I'm working with the criminal system, so I work with the state hospital, and the level of care that people get in the prisons is horrible. It comes nowhere near where it should be. And the people who are left off of medications, psychotic, severely depressed in their cells, in isolation, with no one seeing them, because they can't find providers to go in to work in the prisons.
Yeah. No, thank you for that. I want to ask the question. So we've definitely set the stage in terms of what the mental health issues how they may present themselves, how they effects may appear, and how discrimination, trauma, or systemic inequities may impact mental health for Black men. What I'd like to look at now is starting to get that help. Because as you just mentioned, the way, you meaning Dr. Arnold, the way the jails and the prisons help may not be the best place to do that. So my next question is, I think I'll start with Mark. Please provide us an understanding, and this can go for everybody, but I'm going to start with Mark. Please provide us an understanding of the importance of advocating for proper treatment for mental health issues. So how do you encourage affected individuals to get information from their healthcare providers and others in order to obtain appropriate treatment? You know, with the thought that, you know, doing it now would be better than waiting until it's too late, something may happen and they're incarcerated. So how do you do that ahead of time? I'm going to
And
start.
you're starting with me, right?
Yes.
Okay. Self-advocacy, be educated, informed, and question everything respectively. Have a trusted friend who can advocate for you. Also have a mental health advance directive, or something that's called WRAP, Wellness Action Recovery Plan. This allows your family, loved ones, and support team to know exactly what it is you have agreed to as an intervention should your mental health crisis occur. That would be my contribution.
Okay. Thank you. Anyone else want to piggyback on that?
Yeah, I think people seeking help had to see people like us. They had to see someone that they can relate to.
Okay.
And I've found that, I remember, you know, when you're talking about Dr. Ashley was talking about the person who was angry. I had this one person who came into me, he was at work, worked in the on the highway crew, and he had gone to work one day with a gun and was going to shoot his supervisor because they had a young white guy coming out of college coming in and calling them boys, get that boy, being boy or whatever. And this is a grown man. He's in his 50, late 50s. And I said to him, I said, do you have are you married? He said, yeah. And I said, you have children? Yeah, I have 2 kids. I said, you don't want to hurt them. I said, what you do is give your gun to a friend that you can trust that can put it away for you. And what I'm going to do is work with you on depression. Because he had all the symptoms of depression when I interviewed him, you know, but he came in angry. That was his initial presentation. That's why I thought of Dr. Ashley, you know, and he was able to get on the antidepressant, came out of his depression and able to get back to work. But he needed someone that looked like him, that could talk to him and understand where he was at. I said, I know what you're experiencing. I know what you're facing at work, but it's not worth it. It's not worth giving away your life, throwing away your children and your wife for this.
No,
That's
thank
it.
you. That's a
Okay.
good story. Thank you. I'm gonna ask if either Dr. Ashley or Ebony want to chime in on this. How do you encourage affected individuals to get information from their healthcare providers and others in order to obtain the appropriate treatment?
And as Dr. Arnold said, and Mark said already, I would just add to it that, and you mentioned very early in the conversation about the value of congregational ministry and the value of community. And sometimes we for whatever reason, we forget that there's power and influence in our community centers and in our faith-based organizations. And so to include them as partners in it, educating the faith-based leadership, what's available, how to go about it, and then also helping the faith-based and community leaders to appreciate that we're all struggling. There's no shame in saying I need help. Well, there shouldn't be shame. There is shame. There shouldn't be shame in saying that I need help. And I work with clergy around the country, and they ask the same exact question that you just asked. And one of the things I say is that I tell my congregation, pastor's certifiable. I'm a Black man in America. If you're not, then y'all, we're watching the same movie. If you're watching the movie I'm watching, this stuff will make you crazy. And so because of that, I'm in therapy. I'm a psychoanalyst, but I'm in therapy because I need somebody to talk to about, is it me or is it something else going on? There's a little bit of you, there's a little bit of all the other stuff going on. So to normalize getting help and not to make it as though you're ostracized and demonized for trying to get help. And just to kind of circle back, I was trained by the mother of Black psychiatry, Phyllis Harrison Ross. And Dr. Ross had a Black father and a white mother in Detroit, Michigan. She was accepted to Yale Medical School. And her parents said, there's no way in hell I'm going to send you to Yale Medical School when those white guys rape you and move on with their life. So she went to Wayne, went to medical school in Detroit. But Dr. Ross said every morning she wakes up and says, what stupid stuff will white people do to me today? And she never goes to bed disappointed. That is to say that in the room, I know we got the disclaimers, I can say it, it's not the views of the state, we're good with that. That is to say that there's stress on a daily basis, there's mistrust of organizations and professions, including ours. And with COVID, we have come to the realization that the government can't protect us. So folks walk in the door terrified and anxious, as do all of us. We sprayed the boxes, we washed our hands, and we still got sick. And so they come to faith-based organizations to say, help us make sense out of this, normalize it somewhat, and give us that there's some hope somewhere we can get through it.
Yes, that's rich. That's rich. Ebony?
Thank you. And first of all, I want to add to the panelists on saying thank you for a dynamic topic one, and just having us, the DCR, just having us, New Jersey DCR, I should say that, so we thank you for that. I listen and I'm saying to myself, well, I'm here. You guys got everything. You're saying everything. You're saying the right things. But being that you got me here, I got to say something. Mental health is nothing new under the sun. The only thing new about it is, well, 40 years ago, 45 years ago, we were not in the picture. They were not talking about it as much. Our families was hidden, and we hid the child or the relative with mental health issues. We hid them. So fast forward, even when I just came out of my undergrad, my first job was in the mental health. And I'm talking about culture shock in Philadelphia. Just 20, 23, whatever years old, coming out. And I'm talking about people with some serious stuff and people that look like me, because even at one, it wasn't a large, amount of people, maybe one or two people that you may have seen, but the other ones was hidden and they cope with it. But to add what everyone said, and then Dr. Ashley hit it the best spiritually, faith-based. The faith-based was not, well, even now the faith-based has caught up and said that, we need to be out these four corners and on the streets, really talking to our Black men, our Black babies, because they are out there. And so just to add that, and then there's some other stuff that I don't know if I'm allowed to go into what I do, but I'm here for.
Just as
Right. That's what I said. So
Mhm.
therefore, so as moving on, all these the faith-based, the community aspect, I mean, it hit everything. And Ashley has said something, Miss Henry has said something that I wanted to chime on, but we went into another direction. But everything was on point. This is us now. So while by you having the panel discussion on these issues, we're good. That's good. And I'll leave it there before I go into.
No, that's fine. And actually, I'm going to turn this right back over to you, because what I want to do, I want to ask here, I'm going to shift things a little bit. How can we, the overall question is, how can we create a stigma-free conversation surrounding mental health? How do we stop the stigma? And I want to come back to you, Ebony, so that you can describe to our audience the Brother You're on My Mind initiative.
Thank you again. And Brother You're on My Mind was created back in, I want to say 2001, by our National Grant Officer at the time, David Marion, who was our Grand Boss list. What had happened was there were three individuals that died by suicide. And I think did I say it correctly, Dr. Arnold? Did I say it correct? Died by suicide instead of what, because I know we want to change that. And that's part of changing the narrative of saying someone killed himself or suicide or whatever the case may be, but it's died by suicide. And we had three brothers, young brothers, under 25 years old, that committed suicide. So we realize and recognize the mental health part of what's going on. Just because these guys are in college, just finished, they still have issues. We, as grown men, and have not handled our issues, still have issues. So it wasn't so much of the age, as Raquel said about this. It's not about age. It's about the mentality of a man. We on Brother You're on My Mind was created through that. And each district, which I belong to, and David Arnold belonged to the 2nd district of Omega Psi Phi fraternity, which consists of Pennsylvania, Maryland, New Jersey, New York, and Delaware, 5 states. And we have a district representative. Our 39th district representative is Amir Sharif, who was just elected. And the introduction to you and I, Ms. Wilson, is the first vice district representative, which is
Leon Smith.
Don't tell me, Leon Smith.
Leon Smith.
Leon Smith, yeah. So I say that to say all that. We have Brother You're on My Mind. We meet twice a month. One, have a workshop. Workshop, as well as a meeting, and then we do a workshop for the brothers, talking about every issue. Because for me and the committee, it's not just about mental health. It's about every aspect in their lives of what's going on. We want to be your brother's keeper. We want to be there for you. So we created that, and then our slogan is saying, and I was trying to put it up, and I should have put that up instead of my sweater, but, Brother You're on My Mind, brother to brother, help me help you culturally, emotionally, mentally, physically, and spiritually. You are me and I am you. That is our theme, our aim, and that's what we do. We're able to contact and be involved with our brothers, because we care about them. we care about you. We would like to roll this out into society, but right now we got to take care of our brothers because we have a lot of brothers with some serious issues that we don't need to have them, doing death by suicide. So let me just put this up. So if you didn't hear exactly what I said, but
Hope we
is it-
see it.
you see it?
Brother, you're on my mind. Brother to brother, help me help you heal culturally, emotionally, mentally, physically, and spiritually. Lift it up a little higher. You are me and I am you. So thank you for that, Brother Ebony. So that is men building men. That's a great example of how to stop the stigma. And so what I want to do now is move over to Mark, because you, I want you to describe what NAMI Act Now is doing to help in this space.
I will describe what NAMI Act Now is doing in this space, but I need 1 minute.
Okay.
About nurses, doctors, and other specialists who perpetuate stigma
Okay.
in emergency rooms, emergency departments, in our offices, when they use stigmatizing language like frequent flyers or revolving doors, or they don't admit themselves because of internalized and externalized stigma that they have a mental health issue. So if you're a nurse or a doctor and you're in the emergency department and you've had about 3 minutes of mental health training while you've been in nursing school or medical school and you haven't specialized in that, you have a different attitude and a different approach to individuals who may be coming to you with no insurance at certain times, 3 o'clock in the morning, every Friday night from a bar or something like that. And you already think you know what it is that they need. So you make that prescription, you prescribe that intervention, and you don't listen to what they have to say. And it may take a half hour for them to get what it is that's bothering them. And as Dr. Arnold said before, it could be a medical problem disguised as a psychiatric problem. It could be a psychiatric problem disguised as a medical problem. So I think it's very important that we start to recognize and advocate for programs like MCORT, which is a mobile crisis response team that does not require law enforcement to be at the head of the spear, so to speak, and arrive together, which requires a peer or a community member and a professional to lead the intervention when individuals are in crisis. So that's an important point to make when we're talking about creating stigma-free conversations. Now, on to Act Now. Act Now is a multicultural affiliate of NAMI New Jersey. NAMI New Jersey recognizes that different cultures deal with an individual or a family experiencing a mental health crisis differently. So African Americans, South Asian, Hispanic, and Chinese multicultural groups exist in NAMI National because we want to be able to create a cultural humility that says, leave what you think you know about this marginalized group at the door and listen to what it is that they say. So don't only practice cultural competency, but practice cultural humility and listen to individuals and listen to what they have to say. If you're dealing with 1% of African American psychiatrists and 4% African American psychologists, then you know that you're probably at some point going to need to go to someone and get help who doesn't look like you. So you need to advocate for yourself and make sure that people are listening to you and they're speaking in your language and that they have an understanding of your cultural background and your legacy of trauma that comes from the legacy of slavery that Dr. Arnold had talked about before. That's it for me.
No, thank you, Mark. I'm going to turn to Raquel now. There's a small bit of thunder already taken, but it's okay. We're gonna I'm going to ask you the same general question, but if you could speak to us a little bit about the Seabrooks Washington Community Response Act and how that can be helpful.
Yeah, I'd be happy to. And you know, the gentleman before me, I think they touched on key points of what the legislation seeks to do. I think it was Dr. Arnold who said that seek people who look like you, right? Dr. Ashley spoke to the issue of mistrust, and Mr. Williams, he reiterated as much. So I'll just offer that in January of this year, after more than 4 years of advocacy, we saw the Seabrooks Washington Community-Led Crisis Response Act signed into law. This historic piece of legislation, it allocates $12 million across 6 municipalities in the state to establish or support community-led crisis response team pilot programs. And they would essentially serve as alternatives to police response for nonviolent, mental health, behavioral health, and substance use calls. And it also establishes an advisory council that would be tasked with establishing best practices for long-term success and sustainability of the programs. This bill was the result of public hearings that Salvation and Social Justice conducted in Black churches throughout the state. First, we collected testimonies of directly impacted folks in the community who had to interface with the police, and there was a common thread. Time after time, we heard accounts of police misconduct, abuse, and violence. We followed those public hearings with visioning sessions where we tasked members of the community to reimagine what public safety looks like to them, absent police. And the takeaway was very clear. Our communities live in perpetual fear and legitimate fear of the police. We don't feel safe having a person with a gun report to our home, our schools, our neighborhoods in response to someone who is perhaps having the worst day of their life, right? We understand that to call the police for help in our community is often a gamble, not only with our own lives, but with members of the community. And we also know that there is a better way. So the Seabrooks Washington Act, that was named after Najee Seabrooks, who was a community crisis worker in Paterson, and Andrew Washington, who was from Jersey City, both of whom were killed during the throes of a mental health crisis by the police. But what this act does is it would help support community-led crisis response teams, thereby reducing the likelihood of harm on our communities by police. And it would also serve as really a national model for community-controlled public safety across the country. To date, we have teams like the Paterson Healing Collective, North Community Street Team, and the Trenton Restorative Street Team doing incredible work around violence interruption across the state. This law would allow these teams of directly impacted professionals, again, people who look like you, who speak your language, who've been through what you've been through, these directly impacted professionals to expand their reach and support in communities the way that only they can. They are not simply seeing someone for the first time on their worst day. These are professional crisis responders from the community. They speak the language. They understand intimately the challenges and the needs of the people in the community, and they're personally invested in the holistic health and wellness of the community. I also want to, draw a distinction because, to the state's credit, there have been several programs rolled out in an effort to offer alternatives to just a police response to these calls. Mr. Williams alluded to the Arrive Together program. We have a 988 program. I want to be very clear. The Seabrooks Washington Community Crisis Response Act speaks to community-led crisis response teams. That means that they have been established by, informed by, operated by, and are accountable to members of the community. The visibility of our community-led crisis response teams yield credibility. And that credibility allows opportunities for these crisis response teams to aid and care for residents in need. So that credible messenger aspect, that is the secret sauce. That is what is missing from programs like Arrive Together or 988. Because largely, and we have to be honest about this fact, is that our communities largely are less responsive to predominantly white institutions or predominantly white systems of care. And that's for good reason. There's a historical reason why that is. While both programs, they've done good work in supporting alternatives to police response, their programs ultimately miss that credible messenger aspect. And, you know, the Community-Led Crisis Response Team, Crisis Response Act is an important addition to the continuum of care that we see in the state. Our community-led crisis response teams are not going to subject already marginalized communities to many of the harmful practices that are prevalent in existing mental health institutions and response models. You know, studies have shown that Black patients are especially vulnerable to harm from medical institutions due to the racism and the implicit bias that permeates the field. The practices can appear in the mental health screening tools. They're often used to assess and make diagnosis. The empathy gap that exists between white providers and their Black patients, and again, the absence of culturally congruent staff who understand the language, the needs, the tendencies of communities they're serving. And that last point is especially important because the absence of those things may cause healthcare providers to criminalize behaviors that they just simply don't understand. So it's always important for us to remember when we're talking about models of response that it is very difficult to offer equitable and quality care to individuals or communities when you are consciously or subconsciously fearful of them or suspicious of them or have othered them in some way, shape, or form. So because community-led teams are from the communities they serve, they don't share the same deficits in the care and services that other models may have. And I think just lastly, I'll say that, you know, despite well-intended efforts on the part of the state, you know, we can't take strangers from outside of the community, provide them with a few hours of mandatory training, and think that they'll be equipped to understand the very specific and unique needs of individuals from the community. There's an understanding that comes only from living, breathing, witnessing, and experiencing the circumstances of the community. And that understanding comes from relationships, and we know that the relationships precede the work. So that's why our community-led crisis response models are so important. That's why this bill, this statute is so important. So we're very proud to see that the law adds an important and specific value in the mental health continuum of care. I want to just say that it was birthed from the indescribable pain and trauma that's been experienced by families and communities across the state. And these same communities took their outrage, their loss, their grief, and they constructed a model of public health and public safety response that we are confident will save lives, but will also honor the lives that were really needlessly lost up until this point.
Thank you so much. I want to ask this last question. We're winding down on time. What can community members safely do when they or someone they know is experiencing a mental health crisis? I'm going to start back with Dr. Arnold from the medical perspective and then work our way around.
Okay. Okay, I think one thing, you know, I want to say before I answer that is that we know that mental health has its roots in biology, you know, by the biopsychosocial model. So, you know, it can be biologically driven, and we know that the genetic, it can pass on in families, but in terms of bipolar disorder, depression, and raise your risk. There's a social aspect and also a psychological aspect that impacts the whole system, you know, and gives rise to problems. The one thing I think the barrier we have to break through is to stop thinking of mental illness as equaling weakness. Mental illness does not equal weakness. What equals weakness is choices. The choices we make. So if we choose not to pay attention to our finances, then we end up with problems financially. If we choose not to take care of the people in our families and our lives, in our friends, then we jeopardize those relationships, and we set a bad path for ourselves. So a lot of it has to do with our choices of what we want to do, you know, how we want to handle problems, how we want to deal with a problem that arises. Often we put that aside and we just try to push our way through. And so what will happen is that when you approach somebody who may be having problems, they're going to be very often defensive. and say, no, nothing's wrong with me. Leave me alone. I got everything under control. I'm good. Right. And that then makes a potential for a bad situation if that person then responds in a way that's escalates, you know. And we saw the results of that with when the police, and I mentioned earlier that we criminalize mental health, you know, that is bad behavior. And one of the terms, I know people have used it and they say behavioral health. I don't really like that term. I think it's somewhat pejorative that I'm gonna judge you based on your behavior. I think it has more to do with how the person is feeling and what they're thinking, you know. And but anyway, the response has been on the behavioral level that the person's acting out, they're agitated, they're aggressive, and we throw all those terms out to define what the person's experience is, instead of the person's in distress, the person's upset. You know, we don't hear those words. And so the police come in, and then the person responds to an aggressive stance. Put your hands down, go up against the wall, you know. We're gonna handcuff you now, you know. And a lot of patients I get who come into the hospital, they come in with second-degree assault as one of their charges, almost 100%. And it's because they resisting arrest, you know. And so it becomes a criminal act rather than an act where the person can get help. So that, you know, I think the best way is to have someone that knows the person, that can talk with them and kind of convince them that maybe it's a good idea to get help, to get someone to help them. And it depends on the level of severity, you know, the situation.
Okay.
So if the person's having this mild anxiety and that type of thing, you can try to get them to a therapist, say, hey, I know a good therapist that you could talk to, you know, why don't you just talk to them one time? You don't have to commit yourself to anything. Just talk to them and see what they have to say. You could talk to your pastor, you know, and then pastors are linked to mental health systems often, you know, so they'll say, oh, you might need a referral to mental health if they see that there are real symptoms that are, you know, that are being problematic for the person, you know. The other one is if the situation's escalating where your safety is at risk or the family safety is at risk, then we have what's called an emergency petition, where you can have the person picked up by the police and brought to the hospital. Again, that kind of feeds into the criminal aspect, because what an emergency petition is essentially is a warrant for the person's arrest to bring him to the emergency room to be evaluated. It's the equivalent of a warrant. So that's when you have extreme situations, when things have really gotten out of hand, and then that leads with itself into some danger in terms of the person's safety and the safety of the rest of the family and the people around, you know, around them. So it's always better to get it early on when you see the earlier signs, and also recognize the person's going to have denial. They're going to say, oh no, everything's good and everything else, you know, but to provide them with information, you know, get a pamphlet. If you think someone's depressed, get a pamphlet on depression, just leave it in the house, leave it on the table. And then I pick it up and start reading it and say, oh, man, I had that, you know, I had those symptoms, you know, and it's easier for them to kind of begin to wrap their brain around what's happening to them, you know.
Thank you, Dr. Arnold.
Okay.
Thank you so much. We have 1 minute left. I don't know if Mark or Dr. Ashley, you want
This is
to?
Mark. I would just like to say, learn mental health first aid,
Okay.
and learn symptoms of your loved one. As Dr. Arnold said, there are prodromal signs before someone is about to enter into a crisis. And if you can get those, identify those symptoms and try to get an intervention before it becomes a full-blown crisis, that is most beneficial.
Okay, thank you. Dr. Ashley, I see you unmuted. Did you want to?
Well, three things. So, Dr. Arnold talked about bad behavior, which is how we're trained in our medical schools and in our mental health places. We don't talk about bad systems. And it's the bad systems that impact the individual that creates the bad behavior. That's the first thing. Second thing, we can't go have this conversation. I talk about SAMHSA. At least put it out there that, and under SAMHSA is vibrant. which is the crisis hotline. So we have to put that out there, and we have to do a better job of getting people to look like us on the crisis hotline, but we can't ignore it. The third thing, that because we're talking about Black folks, is emotional emancipation circles. They are nationwide. Look them up if you don't know about them already. It's one of the few efforts where both APAs agree. American Psychiatric and American Psychological both agree on the value of emotional emancipation circles for people of the African diaspora, wherever you may fall and find yourself. Lastly, I strongly encourage that if you're going to have people to work with us, to understand racism, its manifestations, and its history. One of the best ways to learn that is through the People's Institute for Survival and Beyond, that for the last 45 years have been doing undoing racism workshops across the globe in medical schools, in courtrooms, in
Everywhere.
schoolrooms, you name it. And
Okay, well, thank you.
You can't correct what you don't know. If you don't know what racism, the definition, you can't fix it.
Thank you.
If I may, Ms. Williamson,
Okay.
I just want to
Minus
strongly,
30.
I'm sorry, I just want to strongly encourage, also do a genealogy. A genealogy background of one's family would tell them also too that they have had mental health in their family down the line. So that's something else that I offer too as well. But I want to mention that genealogy on one's background is tremendous. It'll help them.
So we call it the genogram, but it's the same thing. That's
exactly. Say genogram, same thing, thing.
Oh, that's great. Thank you so much. I'm writing all of these things down. I've learned a lot. So what we're going to do, thank you so much. What we're going to do right now, everybody stay put. I need to do some presentations. I need to do a little bit right here so that we can kind of tie it into the Division on Civil Rights. And then after that, we'll have some Q&A. I see a few questions in the question and answers. I will ask that if you have questions in the audience to please use the Q&A. I saw one or two people raising their hands. We're not going to answer in that fashion. So please use the Q&A and we will answer those that we can in the time frame that is provided. So I am going to share my screen, and I have more slides than time. So what I'm going to do is just do a very quick summary. But this is what I want to do is just give a very quick Know Your Rights presentation, which is under the New Jersey Law Against Discrimination. And so I'll touch on just a few of these, but basically the introduction to the New Jersey Division on Civil Rights and the Law Against Discrimination, and a little bit in the last three. So let me just go ahead and move here. So in terms of who we are and what we do, the New Jersey Division on Civil Rights was created 79 years ago by the New Jersey legislature. Our mission is to prevent and eliminate bias, prejudice, and discrimination in New Jersey. And we also have our vision, which is a New Jersey where all people are treated equally. The enforcement, we are the agency that educates and enforces the New Jersey anti-discrimination laws of the New Jersey Law Against Discrimination, the New Jersey Family Leave Act, and the Fair Chance in Housing Act. I'm going to focus on the New Jersey Law Against Discrimination today. The Law Against Discrimination, which we also call the LAD, makes it unlawful to subject people to discrimination or harassment in these following areas: employment, housing and real estate, and places of public accommodation. Places of public accommodation could include hospitals or schools, for example, restaurants, places of those nature. Now, within that, the Law Against Discrimination protects residents based on protected categories. And so you'll see here several different categories that are probably very familiar. You may be in several protected categories. There's race and color, but there's also disability, religion or creed, and I'm just skipping around, but gender identity or expression, age. We have about 20 of them. And it's important to note that the law protects you even if it's perceived. So if it's actual or perceived. So if someone is discriminating against you, saying that you're Muslim, but in reality you're Hindu, that still will fall under the law against discrimination, because it's whether it's actual or perceived, they are still trying to discriminate or harass you. Not all bias incidents are bias crimes, but all bias crimes are bias incidents. This part I'm not going to do a lot on, but I do want to just touch on it, that this is where we do civil investigations, as opposed, we don't do the criminal investigations. That's done by another division. We look at acts of discrimination or harassment that violate the LAD, and we focus on whether the employer, the housing provider, or place of public accommodation knew about the bias-based harassment and took the appropriate steps to address or stop it. So in context of what we're talking about today, if you think of a public accommodation as a hospital, did they know about the bias-based harassment when someone came in and said that they had a mental health issue? What did they do about that? The criminal investigations are done by the Division of Criminal Justice or the county prosecutor or local police department. And the bias crimes, they focus on the individual perpetrator and whether or not the crime is committed with the purpose to intimidate a member of a protected class, or knowing that the conduct would intimidate a member of the protected class. You are able to file a complaint with the New Jersey Division on Civil Rights through our NJ Bias Investigation Access System, the DCR online portal, to file a complaint. You would go to bias.njcivilrights.gov. You would see a screen such as this one. You'd be able to file a complaint using that. And then when you go to the next screen, you would be able to file a complaint using everything on the top line. The bottom one is for bias crimes, but if you're looking for civil rights, you can use the everything on the top. And then on the right-hand side, we just also have step-by-step instructions in English and in Spanish. You can do this within 180 days of the actual event. So that's the very, very quick version that I wanted to provide, just so that you have an idea of what is available to you if for some reason you feel your rights may have been violated in this space. I do want to mention, of course, I already mentioned the disclaimer, but I also just want to say we do not provide legal counsel or legal advice, and we do not comment on ongoing investigations or litigation with the New Jersey Division on Civil Rights. So with that, I will show this slide. We can be contacted using community relations at njcivilrights.gov. We're on Facebook and X, also known as Twitter, at Civil Rights NJ. Our website is njcivilrights.gov, and our phone number is 1-833-NJ-DCR for you. And you also have the 711 option for relay. So now I will stop sharing, because now that gives us time for everyone to come back, and we have still several minutes left so that we can go into question and answer. Now, some of these I noticed have already been answered, so I'm going to choose as many as I can, focusing on some that are staying on topic. So, what are the ages of these men encountering mental health issues? Dr. Arnold, you want to start?
Yeah, I think it goes across the age spectrum. And you know, and the level of distress, you know, I think it's more profound like in later life and in earlier life, like in teen years to 20s to 30s. And then later in life, in post-retirement, you know, or approaching retirement, post-retirement. It's where you see the most of the stress, because those are the points in life where either you're starting your life and trying to build it, or you're trying to figure out how to, you know, make it with the rest through the rest of your life, you know, without the things that you counted on before, like your work and your you know, the things that you had, you know, that kind of help you structure your life and keep things stable, you know.
Mhm.
So those tend to be the more rough ages.
All right, thank you.
I'd like, this is
Mike.
Mark, to respond
Yes.
to that in a little bit of a different direction. And Dr. Arnold can back me up on this, is that there's a significant amount of years that go by before young people are appropriately diagnosed and get the treatment that they need. And the same thing with adults. I think it's about 8 to 11 years before, when they start showing symptoms, before they get treatment. And in the meantime, if they're parents, they are parenting children, and these children are modeling the behavior and learning the resistance and stigma that's associated with being fearful of the mental health system and getting the services that they need.
Yeah, yeah, and I think the average from the onset of symptoms to the final diagnosis of bipolar disorder is 11 years.
Okay, thank you. Thank you. This next one, I think I know the answer, but it's pretty brief. This is going to go to you, Ebony. That's a great shirt. Where can I buy it?
Well, unfortunately, the church is not offered to society right now, or the community. It is just offered right now to, I wanted to get a jump start with our brotherhood first. But if you take down my name and number, when I do roll out for the community, you'll be the first one.
All right. Thank you, Ebony. All
Yes.
right. There are 2 comments and then there's 2 questions. So the comments both come from the same person. The first one is: the crisis in schools is not segregation itself, but lack of funding in schools across communities. And the second point: with limited resources, do we have research or information that demonstrates what has worked to encourage Black men to seek mental health support? This way, programs can be designed around what has worked. If not, then there needs to be this type of research. So for that second point, would someone like to come in on that and talk about the research or information demonstrating what has worked to encourage Black men to seek mental health support?
Yeah, I think that the research has actually been limited because you know, getting one of the problems you've had across actually all of medicine is getting people from the Black community to get involved with studies and being and answering questionnaires and surveys, so they can pull the data and get a sense of what's happening, you know. So that's been a real difficult area for our community. So so the answer to that is probably no, that we don't have any program, you know, data that supports one program versus another, you know, and its efficacy. So most of it's just based on experience of what we see the outcomes. So it's almost outcomes driven, you know, stuff. And a lot of the programs don't survive, you know, because of funding. So you see some really good programs that will be there for a year or two, and all of a sudden they disappear, you know. I think that research is definitely needed, and we need to, you know, to look at funding sources as well, you know, and to support those programs. And then the
It's
children, yeah, and actually childhood is really where we have to be very careful, because that's where they're absorbing all the negative images, self-images, and all the negative information as children, and they don't have the psychological structure, the defense mechanisms that we call in psychiatry to support ourselves, to protect them from absorbing the information. So they just take it in until they grow older, and then eventually they develop defenses, but it's already incorporated in their unconscious and directly. So we lead to what Raquel mentioned earlier with the was it IIT I'm trying to think of the unconscious bias, the implicit bias that we come up with, because it's already incorporated in us. So we have to protect our children from negative images.
Thank
But
you. Ebony?
that's why we have two things that we need to continue to stay fast on. That is being an advocate for all these programs and what works, best practice, as well as being supportive. We have to continue to be supportive in what we do. And this way we can formalize or start getting those, I guess, the best models and what works for us, because we do know advocacy works and we do know supporting works. So we need to stay on those two keys.
Thank you. I want to stay on this idea of research and information and just ask the next question. Is there any data concerning the impact of food on mental health issues, unhealthy or government-sanctioned bio/food warfare in communities of the Black African diaspora?
That's
There
good.
are, I'm sorry, go ahead.
No, go ahead. You got it.
The largest studies on the impact of food, to drill it down to the impact in African-American community, people of the diaspora, that, like Dr. Arnold said, we have to do more research on that. However, that being said, we're in New Jersey, you're in Trenton, you have to talk about the studies that were released by Congresswoman Bonnie Coleman Watson. Ring the alarm, sound the alarm. She talks about the crisis of our Black young adults and Black youth committing suicide at record rates. And then that's backed up by a similar study by the Urban League. And so definitely we have to give hats off to her for her work in that area. But clearly she has published, and it's online. You can get the PDF copy for free, talking about the challenges of our young Black youth globally, as well as in the state of New Jersey.
Yeah.
Thank you.
And it actually was a report from the Surgeon General that, said that from 1980 to 1995, the suicide rate among African Americans ages 10 to 14 increased 233%. 233% increase.
You said it's 95 and 95?
From 1980 to 1995.
Well, I can
And
imagine
that's
it's more
time
now.
And it's more now.
There's more now.
Yeah, and as compared to only 120% increase in non-Hispanic whites. So it was almost 3 times the amount increase in young Black children, 10 to 14 years old.
Okay. Last question. How can I create a circle of mental health support for the men in my family? There are challenges to them thinking they don't need it, or it makes them look weak. I think this is a good one to end on as we go back to stopping the stigma.
Yeah, I think the main thing is making a connection with the person. And, my grandmother used to say, David, you were born with 2 ears and 1 mouth. So you listen twice as long as you speak. And sometimes being able to sit there and actually listen to them, listen to the person's story without bias, without making conclusions or making your own thoughts of what's happening. Let them tell you what's happening and make that connection. And then you can tell them, if you have idea of like resources and other things, let them know, first of all, I'm here with you. You need me, I'm here. And the most difficult thing, I think, for anyone who has a physical illness or mental illness is that once you get it, the first thing you feel is alone. Like you're the only one with this. So they lose contact with people around them, So it's really important to make that connection and make it sure the person understands that you are there for them.
That's
And
good.
then you can go back and learn about, once they tell you what's going on, you say, maybe you should get some help. They maybe go see a therapist. If they come back, say, oh yeah, the therapist that thinks I have this, whoever, research it, get the information on it, learn it with the person that you're trying to help. So you know what to say.
Here at NAMI New Jersey, our mantra for this year is "We're not alone."
Yes.
Go
You're
ahead,
not
Mark.
alone.
You're not alone. Yeah. So thank you. And I think we're going to have to end on that because I have to
Oh,
say a couple of things. I'm sorry. But yes, we're going to, oh, you're not alone. And I think that's a perfect way to end. What I wanted to say in terms of the title, I Am My Brother's Keeper. When we think about that, we're saying we're your protector, and you're not just protecting a person when they have a physical issue. You may see when somebody falls down and you go to pick them up. But if you see that same person with their hands on their ears saying, I can't stop the voices in my head, we're still that brother's keeper. And what we have heard tonight are different reasons why that is, but we've also heard some ways that the community is helping heal itself. And we've also, offered several things that you can come back to as well. 988, especially, that's the hotline. If you have something urgent and you need to talk to someone immediately, please do. We will have resources available in the resource packet when we send this out again. So I would like to just thank everyone for this rich conversation. Dr. David Arnold, Mark Williams, Dr. Willard Ashley, Ebony Davis, and Raquel Romans Henry. This was rich. I have a page full, I won't even show you, of notes that I will be looking up these resources and adding them to the list. I also want to thank my team, the community relations unit that is offline, off camera right now, T in her absence, and then also Kai, Angela, Fanny, and Taylor. Thank you, because you may just see one of us, but all of us are doing this together. So I also want to give people an opportunity to take our survey so that they have an opportunity to let us know how we're doing so that we can bring other programs like this to you as well. If you have any questions after this, remember how you can reach us. You can send me questions and I can send them to the people that are here, and we can attempt to get answers for you. So with that, I just say thank you for coming and have a wonderful evening.
I mentioned we're supposed to do a picture.
We're gonna do
Oh,
this.
I'm sorry.
We're gonna stop our recording at this time.